So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. Hello and welcome back, everybody, to another episode of Sanity Podcast. This is part of our ABCT Sanity collaboration series. We have an episode here about cognitive processing therapy, and I am beyond excited to have the person who literally founded this therapy to be on here to talk about the therapy. Let me jump into her bio, and then we'll jump into the episode. Dr. Patricia Resick is a clinical psychologist, professor emeritus of psychiatry and behavior science at Duke University Medical School, adjunct professor at the Medical University of South Carolina, and board certified by the American Board of Professional Psychology. Her specialty is the understanding and treating the effects of traumatic events, particularly post-traumatic stress disorder, PTSD. In 1988, she developed cognitive processing therapy for PTSD, a short evidence-based treatment, and has overseen multiple clinical trials. The treatment manual for CPT has been translated into 15 languages and has been formally disseminated throughout the VA and other veteran services in the US, Australia, and Canada, as well as civilian training initiatives in the US. CPT is considered a first-line therapy for PTSD. Her research has been continuously funded for over 40 years. She has published more than 350 articles and chapters and 12 books on PTSD, including the newly published self-help book, Getting Unstuck from PTSD, Using Cognitive Processing Therapy to Guide Your Recovery, and has just completed a second edition of the best-selling treatment manual, Cognitive Processing Therapy for PTSD, a comprehensive manual. Everybody should probably pick up a copy of that. She has served as the president of both the International Society for Traumatic Stress and the Association for Cognitive and Behavioral Therapies. She has won multiple research and mentoring awards, as well as Lifetime Achievement Awards from the Trauma Division of the American Psychological Association, the International Society for Traumatic Stress Studies, and the Association for Behavioral Cognitive Therapies. And that was my abridged version of your bio. There's more on there. Patty, welcome to the show.
Thank you. Thank you for having me.
Okay, so just to get started, just to orient the listener, what exactly is trauma and what is PTSD?
Yeah, I think sometimes people use the word trauma a little too casually. Actually, I just wrote a blog about that for the Psychology Today on what is trauma. And I think people, use it casually, meaning like something upsetting happened to me and I was really traumatized by it, or divorce, or, I didn't get the wedding flowers that I wanted, and so that becomes very casual. When we're talking about it with PTSD, we're talking about a pretty severe event. It's not that people don't ever have traumatic events. Most people have at least one in their life, but it's usually a life-threatening or self-threatening event that you either witness or experience, or you learn about it happening to a loved one. So we're talking things like rape, combat, hurricanes, tornadoes. We're seeing an awful lot of natural disasters happening these days as well. Car accidents, anything that could be life-threatening or, and I'm saying self-threatening when I talk about rape, because that isn't necessarily a life-threatening event, but it certainly is a very traumatic event, whether in childhood or adulthood.
And when someone undergoes a trauma, PTSD is one potential pathway that somebody could go through. I guess I call it like a trauma response, where it could, there's different responses that people could have to a trauma. What are different pathways or outcomes that could happen if someone does experience one of these critically threatening events?
Actually, most people tend to recover without therapy. That's another myth that I think people have, is like, you'll never get over this. It's going to last the rest of your life. And they don't even know that therapy is available. And it's not that difficult to be treated, if you're invested in getting treated. So probably, maybe 10% of people are going to end up having PTSD over a period of time. In the first 3 months, we see the most recovery. But there was a study that was done a long time ago by Edna Foa and her colleagues, Barbara Rothbaum and David Riggs, and they were looking at rape and assault victims, females who reported to the emergency room, and they tracked them weekly for the first 3 months. And at 1 week post rape, and the numbers were smaller for assault, but for rape victims, using the DSM that was available at the time, which was back in the early 90s, almost everybody met the criteria for PTSD. I think it was like 94% met the full criteria, except the time criteria, because you'd have to have the symptoms for at least a month. So it's almost universal to have symptoms after a major traumatic event. The trick is the recovery trajectory. And there are some people who recover from events quickly, meaning over a period of months or sometimes a bit longer. I mean, there's been some research that has shown that, people continue to recover after 3 months, studies that have tracked people for a year or so. There are people who have symptoms that go up and they stay up. And I think usually what I've seen in some of the research, it looks like at about a month is when the avoidance really kicks in. They're saying to themselves, why aren't I better now? Or I should be better by now. Or, I got to stop these symptoms. They're driving me crazy. So they'll drink or they'll eat or they'll do something, high functioning people with PTSD would just avoid through sheer dint of will, that they're going to refuse to think about it. Anytime they're reminded of it, they're going to push it away. And there are a few people who have a delayed response. I don't see that very often, but there is a small number who have that. And sometimes that's because the meaning of the event has changed. Like a battered woman gets out of the situation and then her former spouse kills his next partner. And all of a sudden, the meaning of it totally changes, and she rethinks everything that happens to her, and she realizes she was in danger of being killed when she hadn't really before. So we've seen that. I've seen that with rape victims. I've seen it with battered women. So sometimes people reinterpret the event and then have symptoms, and have kind of a delayed onset. And there's some people that have very few symptoms and just kind of stay low. And I don't know if they're underreporting or whether they're just taking it in stride because they didn't expect, they expect things to happen, and they're old enough to understand that good things don't always happen to good people. And that bad things can happen to good people, and they just take it into stride and are much more approach-oriented rather than avoidant-oriented.
So there's three major principles that that you talked about here. One of them is that a trauma response in the beginning is a natural mechanism. It's not a disease per se, but we're built to do it. And the issue is when it gets stuck on, and then it becomes not useful or maladaptive.
Right.
And then you also talked about avoidance and the just world hypothesis, which seem to be two mechanisms that maybe cause someone to get those symptoms stuck on the on switch.
Right.
So can you talk about those three things a little bit more?
Yeah, coming from the fear side of it, that's where we would be talking about the fight-flight response. And when people have that fight-flight response, it tends to generalize after the trauma to other things. So if you're hit by a blue truck and are badly injured, the next time you see a blue truck, even at a distance, you might have that fight-flight response again, and have that huge response. And if you become avoidant of being out on the roads or seeing anything, then it's possible that you would that would continue to grow, and you would continue to have those kinds of responses. And so that's where the avoidance would then kick in. So you're doing escape and avoidance to stay away from the things that remind you of the trauma. Don't think about it, don't deal with it, run away from it. And the problem with that is, of course, if you are running away from things that are not intrinsically dangerous, blue pickup trucks aren't any more dangerous than red pickup trucks. But if you're avoiding something, then you never learn that it isn't dangerous. And so that the avoidance maintains it over time. So one of the problems we have with people with PTSD is they do an awful lot of avoidance. They avoid their feelings about it. They avoid thinking about it. They avoid any kind of reminders of it. And that actually maintains the disorder and can help maintain the disorder for years. And they never think about it any differently. Now, with regard to the just world, that is one of the cognition pieces of PTSD. There are some people who do not have a fight-flight reaction, and some people who have a fight-flight reaction and have cognitions about it where they blame themselves. From the time you're born to the time you die, you're always taking in information. And one of the things that we take in is, like we learn to label at a very early age, 1 and 2, we're learning all sorts of words. And we're learning dogs, they're different than cats, different than cows, and the cows go moo, blah, blah, blah. So we're learning to how to categorize things. But we also categorize events. And one of the ones that I shouldn't say almost, everybody is taught the just world. Because we don't tell small children, don't touch the hot stove, you might get burned. They're going to say, don't touch the stove, you will be burned. Or don't run into the street, you will be hit. So they have such an adamant either or kind of statement to deal with kids. If you behave, things will work out. If you don't behave, you're going to get punished. And because kids can't make those discriminations, you don't say to kids, if you misbehave, you might or might not get caught. Or if you behave, things might or might not work out. So we tend to learn the differences as we get older. When we see bad things happen to good people, and you can't figure out what they did wrong, and people will just say, well, sometimes people get cancer, sometimes people have bad things happen to them. And so if you're older, when something bad happens to you, you may have already adjusted the just world a bit, although people tend to revert a bit when a trauma happens to them. When I do speeches or I go do trainings, I'll say, is there anybody in the audience who's never in their life said, why me? And nobody's hand goes up. Almost everybody at some point in their life says, why me? Well, if you say, why me? My response, of course, is, why not you? Just world thinking is, I'm a good person. Bad things aren't supposed to happen to me. So you say, why me? You're saying it shouldn't have happened. So when you have that just world belief, and it's still in there, whether you think it rationally in your quiet moods or not, when trauma happens to you, that tends to come to the fore again. But what happens is, if we want to believe that good things happen to good people and bad things happen to bad people, we tend to take and alter the event to keep those beliefs intact. And we call that assimilation. So then you say, why me? What did I do wrong? Why am I being punished? I should have done this. I should have done that. If only I had done this, it wouldn't have happened, or I could have saved that person. And they get stuck on that idea. They don't really look at the whole picture, but they just get stuck on that idea that they should have done something different. And that's what we call assimilation. Now, if you had been abused from birth, you've got emotionally abusive parents, or physically abusive or sexually abusive people, you may grow up with the negative beliefs. And so your whole system is, bad things will always happen to me. So if you have another trauma happen, it just fits right in. And you say, see, more proof, bad person. I'm a trauma magnet. Bad things will always happen to me. So it's possible you can start from thinking that you're immune from trauma, or thinking that traumas will always happen to you because that's when your whole life experience is. So we don't want either of those as therapists. But that's assimilation. And then what happens is, because of what they said to themselves about the trauma, then when they look at their current situation or the future, they tend to take that and then overgeneralize. So I couldn't trust this person who did this to me. That means I can't trust anybody. So they'll go from one extreme to the other. They used to think they could trust everybody, just world. And then something bad happens to them. Oh, that means I can't trust anybody, or I can't trust this gender. I can't trust this race. I can't. People will always try to harm me. The world is entirely dangerous. Bad things will always happen to me. So that's what we call over-accommodation. So, when we're looking at PTSD, we're looking at those kinds of cognitions as well as just a fight-flight response or a dissociative response. So there's a biology to PTSD, and then there's also the whole cognitive piece that keeps people stuck.
Yeah, and it's adaptive in the beginning when something traumatic happens for you to learn fear quickly, for you to overgeneralize it a bit, because it's better to be wrong and alive than wrong and dead.
Yes.
But then the idea is that as you not avoid, or as you approach, you then start whittling down that learning, so then it becomes more narrowed and curated to what the lesson should actually be.
Right.
Like, not all blue trucks are dangerous.
Yes.
In your example.
Yes.
But walking in the street where trucks are, that's probably a good lesson to learn not to do that.
Right. So, when a therapist is working with somebody, they're trying to help them not just look at that narrow view that blue trucks are dangerous, like maybe that was an irrelevant factor to the trauma itself, the fact that it's a blue truck. But yes, you don't want people doing dangerous things, but you also don't want them avoiding to the point where they won't go out and they won't drive, they won't be in the streets, etc. They'll stay home all the time.
And you mentioned on the cognitive side that the just world hypothesis is one major belief system that could pull people into a more of a continued symptom direction. Is there any major other cognitive belief buckets that tend to get these symptoms stuck on, or bring people to develop PTSD?
People tend to have hindsight bias, which fits right into that. I should have known that this was going to happen to me. I should have picked up on the cues. Maybe I did pick up on the cues and I ignored them, or I had a feeling that day. So we would call that kind of hindsight bias. After the fact, you think you should have known. And so you still end up blaming yourself. So self-blame is just rampant in PTSD. Shame, guilt, are very strong, and especially because if you're picking up messages from if the event is caused by somebody who's blaming you for it happening, you make me hit you, you're just a slut and that's why I raped you, you deserve this, and they internalize that, then they have shame and believe what they were told, and especially if something happens repeatedly. People who've had child sexual abuse are often groomed to where they're given lots of loving treatment when maybe they've been neglected or not given much attention. And then they're slowly brought in, and then they're doing things that don't feel so good and they don't like it so much. But then the other person is saying, well, but you're a participant in this. You're also guilty. And if anybody finds out about it, you're going to go to jail. So they end up, getting caught in that trap of believing what other people tell them.
Yeah, and they're so young that they're going to believe what a trusted adult is, an influential adult is going to tell them.
Right, and if a trauma happens to you later in life, then you're going to go right back to that early belief because it hasn't been changed. Because when you avoid your feelings, your thoughts, your physiological reactions, all those things that get triggered, nothing changes. And so there's nobody there to say, what are you talking about? You were 5. You couldn't possibly have fought this person off. So you carry that thought with you. And then if anything else happens, you just assume that thought is correct.
So we have two major mechanisms. We have the fight or flight fear response and the avoidance. We have the belief buckets. Any other major mechanisms that are put into play that might have someone fall into the PTSD side versus recover?
Dissociation would be one. That's also part of the biology of PTSD. When when you have a fight-flight response, that's trying to get you to do one of those two things, fight or flee. So all the blood leaves your stomach and you stop digesting lunch, and you don't, you don't get new cells. You can, if you keep having fight-flight reactions, you can get sick very often because your immune system shuts down. If you're about to die, who cares if you're about to catch a cold? It's irrelevant. Your brain kind of shuts down. Your prefrontal cortex turns off. And if you have PTSD, it really turns off to the point where it doesn't tell you when the event is over. In a normal fight-flight response, your prefrontal cortex, the thinking part of your brain, would dim down, so you're not thinking about your philosophy of life or what kind of job you want to have. But what happens then is that when the threat is over, you say, oh, whew, okay, I didn't hit that car. And then you go, okay, I'm safe. And so things quiet down, your amygdala quiets back down, because that's the thing that had gotten triggered and sent out all that fight-flight neurotransmitter stuff. But if the danger continues and you can't stop it, like for example, if you're a child, or if you're under extended combat and you can't fight or flee and you're like pinned down, you might dissociate. And we see this particularly with children who are sexually abused. They can't fight, they can't flee. And so what happens is they go into what's more like a survival mode. The blood goes back to the core because you had the blood going out to your hands and feet to fight or flee. That's not working. So now it's going to go back to your core. Your heart rate, different set of neurotransmitters. Your heart rate slows down so that you don't bleed out. The endorphins kick into your head, so that your morphine is kicking in so you don't feel pain. And you have the side effect then of having morphine in your head, which means you're going to have those perceptual things that happen with dissociation. There's nothing magical and mystical about dissociation. It is a biological response when everything else fails. It's just to kind of stay survived. And so you have that sense of being outside of yourself, watching it happen to yourself, that depersonalization, derealization kind of sensation. Well, that's going to interfere with a couple of things. One, the memory doesn't go in properly. It goes in a fragmented way. So we often have to have them kind of put the story back in the right order. And we also have to teach them not to dissociate, because if that becomes their go-to, just like fight-flight can be somebody's go-to mechanism, that's really bad for your health. It's also for young women, if they've been sexually abused as a child and somebody comes onto them and they dissociate, the event goes on without them and they're gone. They're out of it. So they're in danger. So you got two rationales for not dissociating, because sometimes when people dissociate, they kind of like it. It's almost like an addiction, except it's not an external addiction. It's an internal one where they can, like, whew, I'm out of that. I don't feel the fear anymore. It's shut down. That's why sometimes people will cut themselves, because that triggers that pain shut down, and they'll say, this feels better than this. And so you get people who are cutting themselves or hitting themselves or whatever to get that response. So we have to teach them, actually, you don't want to do this because it's bad for your health and things can go on without you. And you're not going to recover from your PTSD, which is another good one. So we may have to teach them grounding techniques first before we would do the treatment. But the dissociative response could be part of that biology of PTSD.
It just fascinates me how our body is just so built to protect us. Yeah. Whether it's fight or flight, or, I never had someone describe dissociating in those terms, with the blood pulling in and the endorphin, the natural morphine kicking in. And it makes so much sense when you think about it from this biological protective standpoint as to why that mechanism is even built in our DNA.
We first saw that when I was in St. Louis. We were doing a study where we were looking at people at 2 weeks post-rape and then 3 months later. And at 2 weeks post-rape, those who had really high dissociation during the traumatic event, we had a paradigm that was set up so they would just sit there quietly and relax for 5 minutes, and then they would talk about something neutral for 5 minutes. We give them neutral topics, and when another 5 minutes of rest, then talk about the trauma for 5 minutes, and then 5 minutes of rest. Those who were not dissociative during the rape, who had low or medium dissociation, they had the fight-flight response. Their heart rate, when we were measuring it, when they started talking about the trauma, their heart rate and skin conductance went like way up. The high dissociators, it was like a cliff. And so it went up a little bit just because they were talking about something neutral. But then when they started talking about the trauma, their heart rate and skin conductance totally just, it was like a cliff. It just plummeted. And that's the first time we actually saw that with skin conductance and heart rate, that they really had gotten into that shutdown response. Now they're obviously doing fancier things now with imaging and that sort of thing. But that was back in 1994. We were saying, hey, maybe there's a dissociative subtype. And back then they didn't listen to us. But now we have a dissociative subtype to PTSD.
Yeah. And I would imagine falling in that subtype, it's partially situational, meaning you couldn't escape, and so that mechanism had to turn on. But I would imagine there's other like genetic factors, predisposition, almost like everything in psychology. It's multifaceted for why the thing exists.
Well, probably. I mean, it's interesting because when they started looking at the possibility of doing a subtype for dissociation, they looked at the epidemiology studies, and it appeared that there was just this small group, about maybe 20% of people who had a highly dissociative response. Mm-hmm. And then when they did the imaging stuff, same thing. And then we looked at our treatment data, and same thing. The people who had done written accounts rather than just doing the cognitive therapy did better when they did the written accounts. So there was this group, again, not low and medium dissociators, but a high dissociative group that had to do the therapy a little bit differently.
Yeah. So, and you said around roughly 20%?
Yeah, it was about 20% or so.
Yeah, and that's not insignificant.
No, it is not, which is why you kind of have to know that and learn how to deal with it. Now, some people, you can just deal with it during therapy and have them, or keep a card with them if they start to dissociate, where they pull it out and ask themselves some questions like, what's the date? Where am I? What's going on here? So they get themselves back in the here and now. Sometimes people would have to do something specific. Like we have a video example of somebody dissociating on our website, where we do a training website, and there's some examples, and she said something cold, so they would bring in a can of soda and put it on her neck to help her to get back to here and now. For some people, it just might be standing up if they've been sitting down. I mean, just something that's going to disrupt that dissociation. Some people use smells that are pleasant. So they may just need something to help them break up that dissociation and then go back and stay in the here and now. So the whole goal is to stay in the here and now while you're working on the therapy. And then eventually grabbing a worksheet instead of dissociating.
Do you find that a lot of people talk about grounding techniques now and doing in all sorts of different therapy? Do you think that so it was used to help people pull them back from dissociation to bring them back into the here and now? Do you think it's useful in how people are using it when like someone's worrying, grounding in order to pull them back to the here and now, or are people kind of using it off label?
I would say that's probably off label unless it's been researched. I think of ruminating and worrying as being quite different than dissociating. Rumination is closer, and Anka Ehlers and her group were looking at rumination for a while, and they realized that one is not an intrusive symptom, and it's not a dissociative symptom. It's actually more aligned with avoidance.
Yes.
So when you're ruminating, if only I had done this, if only I had done that, and thinking about trying to unring that bell and make the trauma not happen, that's a form of avoidance. You're not accepting that the trauma happened. You keep going in circles. but you're trying to think about how you could have made the event not happen.
I had Bob Leahy on about worry a couple of weeks ago, and we very much talked about how worry and rumination is avoidance of accepting, like if somebody's worried, is that girl or guy, or are they going to call me, or are they going to text? Are they going to text? You're not accepting the fact that maybe they're just not that into you. So you call all your friends. What do you think is going on? And so doing all these things, it's a form. Even though you're doing a lot of activity, you're doing activity in a safer place, which therefore is avoidance of what you're really scared of, that they might just not be that into you, or my boss is going to fire me, or, I did poorly at X, Y, and Z.
And in the case of PTSD, they're looking back at something that happened. And when Bob's talking about it, he's talking about current and future worrying. But yeah, we agree on that.
So we had talked, you talked about two different trauma stories, one where one massive event happens to somebody, and then you've also talked about like repeated sexual abuse, like repeated trauma. Do we have different terms for those different type of traumas? Is having a lot more frequent lower level trauma any different than having one big event? Like, what are we seeing in the literature?
Not necessarily, because, well, at least in terms of people who come in for treatment, most people don't come into treatment after one trauma. They handle it on their own, or don't handle it on their own, but they don't go to a therapist. Therapists are your last resort. But most of the time when we've done research and we've looked at their trauma histories, even if we think we're treating one thing, we may be ending up treating a whole lot of different things. So you could have serial events where it is a series of similar, but not necessarily the same. So even when we're doing CPT, we would have them, if they were domestic violence or child sexual abuse or combat, we'd have them pick out the worst meaning the most PTSD symptoms, the one that they have the most nightmares about, the one they have the flashbacks about, the one that they avoid thinking about the most. And sometimes I'll even have I'm doing training now, I'll have the therapist say, which one don't you want to tell me about? That's probably the one they need to start with. But even within a series of events, there's often one that's worse. The child sexual abuse survivor who finally says no, and he does it anyway. And she thought if she had just said no, that it would stop, and it didn't. And so that becomes, in that sense of helplessness and hopelessness that is going to continue regardless of what she does. The battered woman who kind of has the illusion that because her kids aren't seeing it, that they're unaware of it. But of course they're hearing it. They're seeing the bruises the next day. And then when she recognizes that her kids are being scarred by what happened to her, and that there's a particularly bad one, or when she realizes she could die, or the first time he abuses the children, she thought she was keeping them safe, and now he's abusing the kids. That could be the worst one. So we always go for the worst in therapy. We go for the worst one first. So even if it's a series, very often there's one that's, I would think of as the kind of the linchpin event, and along with that maybe a linchpin stuck point. But we're always looking to start with the worst, because if you start with a lesser one in therapy, you'd still have to work your way up to the hardest one. If you start with the hardest one, the other ones tend to fall away.
And that's what we call an index event in the protocol?
That's what we call the index event. It's the one that you're going to start with. And it doesn't mean we're always correct, but we always try to start with the one that is causing the most PTSD symptoms. If they literally can't come up with one that's worse than the others, and we've got ways of helping therapists help them think through that. But if they literally say they were all identical, we'd say, well, let's go for first PTSD, because however they were thinking and feeling about the first one is likely to continue on.
I see. With index events, because you noted, well, there could be numerous traumas, but could be one that's really stand out for various reasons. Is it usually just one? Is it 1 to 3? Is it 1 to 20? Like, how many index events do you find that really like have an emotional punch for people?
In terms of treatment, we probably never treat more than 2, maybe 3. I've
Mm-hmm.
seen, usually what happens is that they have, I'm going to use the term we use, is a stuck point. They're thinking about it. They tend to think across the board. And so it's very unusual for them to have different set of stuck points for one event than for other ones. So the one that's the worst is if we're going after those thoughts that they have about that, it's likely to generalize to other traumatic events that they've had. Now, sometimes it'll be something so different, like the child sexual abuse, and then your son commits suicide. I mean, you could have a totally different set of stuck points about that, but maybe not.
Mm-hmm. When I talk to clients about exposures, I talk to them about like Venn diagrams, and the more that the Venns overlap with the incident, when you do the exposure, it'll generalize to the things that have a lot of overlap. But if something is a circle that's pretty far out from overlap, it's going to have less of a impact over there, which is like almost a visualization of that concept that
that makes sense.
That you're talking about, like neurologically, the way that things are networked memories. We hear this term complex trauma thrown around a lot. Complex, I hear it a lot more than complex PTSD, but complex trauma, I'll get an assessment report and the diagnosis is complex trauma, even though it's
there
not.
There is no such thing.
There's no such thing. So what are people talking about, and what is this phenomenon that's going on here?
I don't know why people use the term complex trauma. To me, that doesn't have any meaning at all.
Isn't trauma complex enough?
Yeah,
without having to then say it's complex.
Yeah, I don't know what would make it more complex. I mean, trauma is trauma. If you got PTSD, it was bad enough to cause the PTSD. So I don't know what they mean by complex trauma. When they're talking about complex PTSD, there's a lot of debate in the field about that. In the U.S., I was on the last 2 DSM committees, the 4 and the 5, and we looked at the literature and all the evidence and just did not find everybody who had complex PTSD had PTSD. So we expanded the criteria, some of the symptoms to cover some of that stuff in the DSM-5, but still stuck with saying, no, there's not a complex PTSD. That's a separate diagnosis. Now, they did a whole different thing over with the ICD. And this is the first time the ICD and the DSM have totally split. They've got simple PTSD and complex PTSD. But to me, just because you've got affect regulation problems and problems with your sense of self, it's like, to me, that's part of PTSD. And they're leaving out other things that what I would consider that makes it more complex, like substance abuse or an eating disorder or, really serious depression. That's not included in complex PTSD. They're only talking about what happens, particularly with child sexual abuse, where you have problems with identity and affect regulation. But then I also happen to think that a lot of disorders have affect regulation. If you're depressed, you've got affect regulation problem. If you are anxious, you're having an affect regulation problem. If you've got any number of other disorders, you're trying to manage your affect, like OCD, you're trying to make yourself less anxious by doing all your rituals and things. So I just don't see it as being that useful with PTSD. And from the beginning of all of our treatment studies, both what we were doing in prolonged exposure and cognitive processing therapy, which started at about the same time, we didn't exclude those people. They were always included in all of our trials, and we got really good results. And most of the complex PTSD, I was just reading a lit review or a meta-analysis today on complex PTSD. They didn't compare it to just going straight into therapy. Going straight into prolonged exposure, straight into CPT. They just say, if you do phase-based treatments to help them manage their affect regulation to begin with, it works well. It's like, great if they don't drop out of therapy.
So what is the main delineation that they say this person has complex versus non-complex? So it's the emotion regulation, self identity or image issues? And is there any
I
other?
can't remember. They've got, it changes over time,
Okay.
but it's usually they're talking about people who with a child sexual abuse history and
Mm-hmm.
sometimes they don't even, they'll say complex PTSD and then the only thing they do is include people who had child sexual abuse history and don't measure complex PTSD. So the literature's kind of a mess. So they tend not to measure this construct of complex PTSD.
Hmm. Um, you had mentioned in the beginning that people have been using the word trauma, much more colloquially in everyday language, and you also talked about how the lens in which we interpret how events happen to us then impact how we react to it. Do you think that this cultural trend, I'm sure part of it's TikTok driven and various different factors as to why people are labeling things traumas more readily, but do you think by people taking everyday adverse events, I call them adverse events, and then calling them a trauma makes them have a stronger reaction because of that interpretation? Not necessarily develop PTSD, but do you think it has an impact on globally the principle of mental health?
I think that's an interesting question. I don't think I've seen it studied that way. But yeah, I think if you had it in your head that you've got this trauma that's untreatable, and I think that's where the trick would come in, that like, I'm not going to recover because this thing was so bad. It's ruined my life. And there are lots of horrible events that happen to people that would not necessarily result in PTSD. They might result in anxiety or depression, other kinds of reactions, substance abuse, that could ruin your life if you're taking them and coping in bad ways. But they don't necessarily cause PTSD. Divorce does not cause PTSD. Your father dying of a heart attack doesn't cause PTSD. It's a horrible event. It might totally change the life of your family. But we're talking now something else entirely. So whether they recover or not probably depends on how good the family is, how supportive the family is, what kind of resources they have, and how they interpret that event within the family. If you say this is a disaster in my life and you're going to treat it that way, then it probably is a disaster in your life, as opposed to recovering from it and moving on.
Yeah, I just had a supervisee say she had a traumatic event. Her father passed away. And then me saying, well, we're not going to label that as it's a horrible event. It's awful. It could fundamentally change your life. It could create symptoms. It could cause a whole host of things for the person. But labeling it as trauma is probably a mislabeling here. Unless the father passed away by some sort of extreme
murdered
means, like we had murdered or something like that.
Yeah, that's correct. And when they do the epidemiology studies, they don't find PTSD as a result of those kinds of things. I mean, even with something as extreme as 9/11, it was proximity to the buildings, the trade towers that came down, and it was also, you could be across the country, but if somebody you loved was in the building and died, so it's proximity to the meaning of the person to you and proximity to actually witnessing the event. So people who were uptown were less likely to have any kind of PTSD, and people all over the country who were watching it over and over again on TV did not develop PTSD. So they might be upset, they might be angry, they might, have all sorts of reactions to it, but not PTSD.
That's absolutely fascinating. It brings me to my next question with off of the tails of COVID, with there being more societal unrest, not just in the United States, but globally. And it might be too soon because research always takes time to develop. Yes. We have to wait to do the research. But are rates of trauma and PTSD going up with how things have been going?
I have not. Yeah, that's the problem. I have not seen any new epidemiology research on that. There's been a little bit on COVID, And it tends to be mixed. I think if you thought, there's the two populations that are affected by COVID. One is the physicians in the early days of COVID, when there were no vaccines and people were just stacked in hallways and dying. I mean, we lost 1 million people during COVID. So those people, many of them, I think some of the healthcare workers were very traumatized by some of that, what they were witnessing. And because of that helplessness of being able to do anything to help them, there were no treatments, there were no vaccines. I mean, it was just chaos. And then, of course, the families who couldn't go to the hospital with their family, couldn't be with them when they died, couldn't even have a funeral for them. I mean, I don't know if you remember how horrible it was in those first 6 or 8 months.
Oh, yeah. I was in Manhattan. I mean, I still am in Manhattan. And, it was, yeah.
So
we were applauding out the windows at a certain time every day for the healthcare workers that were, navigating all this.
So, I mean, I think, but I think exhaustion and depression would probably be just as likely as PTSD. It would just depend on what they have actually witnessed and the helplessness that they felt at the time. But we don't have really good research on it. So I think the research findings are kind of mixed. Just because somebody got COVID or got diagnosed with COVID, or even getting diagnosed with cancer, doesn't necessarily mean you're going to get PTSD. We don't find that much PTSD with illness. And you might recover just fine. You might have long COVID, in which case you might get depressed over the fact that you have long COVID. But that doesn't necessarily mean you have PTSD.
Okay, so let's take a pause here. We're going to come back. We're going to have an episode diving more into cognitive processing therapy itself, and maybe talk a bit more about the nature of trauma.
Okay.